Hello, this is Kim Jong-il. In today's lecture, we will cover a case in which twin block appliances were used. This 13-year-old male patient with the CC of a protruding mouth visited us. From the natural head position, we can observe the maxilla is quite normal, but the mandible is located posteriorly. The crowding of the mandibular and maxillary anterior teeth is not so severe. The mandibular midline is deviated to the left. The right side shows a Class 1 canine key, while the left side shows a full Class 2 canine key. This patient has a midline deviation. How would the midline look in the panorama X-ray? The mandibular and maxillary midlines match. When the bite block is bitten with the incisor to take the panorama, the mandibular and maxillary midlines match. In other words, the mandible deviates to the left as occluding. Let's look at the PA view. There is a slight difference in posture, but not by much. The maxilla, mandible, and maxillary occlusal plane also show no significant difference between the left and right side. However, while the maxillary midline is more or less normal, the mandibular midline is deviated to the left. There is slight crowding in the maxillary and mandibular dental arches. How is the torque in the maxillary right posterior region? The maxillary right posterior crown is more lingually inclined compared to the left. Therefore, the mandible is likely to deviate further to the left. The palatal plane angle of this patient is plus 3.0 because the ANS is located below the PNS, and therefore the ODI is 76. The facial angle is 83. The AB plane angle is minus 12 because the A point is in the front, and the APDI is 74. The combination factor is 150. The ODI is 76. Does this patient have a tendency of open bite or deep bite? Since the ODI is greater than 74, we may diagnose that this patient has a tendency of deep bite. In this case, we could treat this by extruding the mandibular molars to further push the mandible forward. On the other hand, it is also possible to diagnose that the patient has a tendency of open bite because of the small CF value of 150. In cases such as this, where the ODI and CF suggest opposites, which should we prioritize? The CF should be prioritized. Many people prioritize ODI, but we should prioritize CF and diagnose open bite for this patient. Please remember that CF should be prioritized over ODI when diagnosing vertical skeletons. Therefore, this is a Class 2 high-angle case. The ODI is 76, APDI 73, CF 149, Class 2 high-angle, FMA 36, so big. The U1 to lip line is 2.7, which is normal, and the UOP is 18.6 and the POP is 24.2. Both are steep. The mandible will be posteriorly located. The U1 to FH is 120.4, and if we look at the IMPA, there is labioversion in both the maxillary and mandibular incisors. The interincisal angle is small. Therefore, we can observe the tendency of a protruding mouth from the E-line. Let's look at this patient's list of problems. 1. A protruding mouth which requires extraction. Minor crowding which requires non-extraction. 3. Large overjet, which may require extraction. 4. Midline deviation, which requires us to match the maxillary and mandibular midlines during treatment. 5. Labioversion of the maxillary and mandibular incisors, which requires extraction. 6. Steep POP, which requires the uprighting of the molars. The problems of treating this patient with non-extraction are the combination factor is small, the mouth is protruding, and the interincisal angle is small. The issues that may arise when the patient's premolar is extracted are dished face, deep overbite, difficulties with key correction and aligning the midlines. But this patient is still growing. If this patient was an adult, we can extract only the maxillary premolar. First, let me explain the left-to-right asymmetry. Possible treatment plans are either non-extraction or extraction of only the maxillary premolar. However, because the patient is still growing and the edge-to-edge bite profile is not bad, non-extraction treatment is possible. When treating class 2, if there is a large combination factor and MX protrusion, I personally use headgear and ABP. However, this patient has a small combination factor. The edge-to-edge bite profile is good. Thus, we can use twin blocks. If there is protrusion for edge-to-edge bite and a big combination factor, we can use a headgear. If we use a headgear considering the possibility of deep bite because the ODI value is 76, the mandible is likely to be pushed further backwards. This is why vertical analysis is critical for treating class 2 malocclusions, and the CF should be prioritized. Treatment is more convenient if we use the twin block appliance first and then perform strategic leveling afterwards. First, the twin block appliance is put on. The screw is turned twice a week. The twin block appliance was adjusted to align the midlines. How do the left and right sides of the maxilla look? The right side of the maxilla is narrower towards the palate. For cases of class 2 malocclusion, there must be a transverse problem. Class 2 often has a negative curve of Wilson in the premolar region, and narrow intercanine width and transpalatal width. In this case, it is better to expand the maxilla. Treatment is easier if we expand the maxilla and improve the antero-posterior relationship simultaneously. The twin block appliance is the device that makes this possible. In twin block appliances, we can also add expansion screws in the maxilla. If we look at the clinical control process, the twin block is always worn except when eating and brushing teeth. And the screw is rotated twice a week. In the second month, the space in the maxillary anterior region is checked, and brackets are attached to the maxillary anterior teeth. If the maxilla is narrow, the screw should be constantly rotated, and the twin blocks should still be worn at night. In the third month, space will be created in the mandibular anterior region as well. At this time, brackets are attached to the mandible as well. After the anterior dentition is somewhat aligned, the twin blocks are no longer worn. The patient may ask you how many months should wear the twin block. It is usually worn for 3 to 4 months full-time for the first month, and only during the nighttime from the second month. Remember that bracket bonding should be done from the second month. The maxillary anterior teeth are arranged and open coil spring is used around tooth number 6. The mandibular anterior teeth are also arranged, and open coil spring is also used around tooth number 6. If we use a twin block, the meshally angulated and meshal rotated mandibular second molar will be uprighted and derotated. The premolars move slightly forward. The class 1 canine key and the premolar key are maintained. After strategic leveling of the dentition, a bracket is attached to tooth number 6, and MEAW is engaged on the mandible and maxilla. Short class 2 elastics are used for aligning the mandibular and maxillary midlines and adjust occlusion. The rubber bands used here are 3/16/6 Oz rubber bands. This is how the treatment is completed. What used to be a left full Class 2 canine key became a Class 1 canine key. We can observe that the mesially angulated mandibular molars have been uprighted. The mandibular third molar can be extracted later. If we compare the PAs before and after treatment, we can notice that the maxillary and mandibular midlines have matched. The treatment process took 11 months. The APDI changed from 73 to 79. It is now a Class 1 skeleton. The combination factor remained at 149.7. However, the POP flattened from 24 to 16. We can observe that the mandible is moved forward by the twin block appliance, and the mandibular anterior dentition is also moved forward accordingly. The mandibular dentition moved forward, followed by the backward movement of the maxillary dentition. It is important to note that the combination factor did not change. The mandible was moved forward due to the flattening of the steep POP. It is possible to move the mandible forward by using maxillary and mandibular mio. But using a twin block appliance is much more reliable in terms of results. We can notice that the post-retention is well maintained. Here are the lateral photos of pre-treatment, post-treatment, and post-retention, and the intraoral photos of the maxilla and mandible. Especially in cases of midline discrepancy, we can notice the difference in the crown buccolingual torque on one side of the maxilla. We must solve this first before we treat midline discrepancy. We can observe the mandible, which was placed slightly posteriorly before treatment, protruding anteriorly after treatment. The mandible may be moved further forward with the growth of the patient. Because this patient is growing, the mandible could still protrude forward regardless of the small combination factor. If we look at the photos of pre-treatment, post-treatment, and retention from the front, left and right, we can notice that the full Class 2 canine key on the left has improved to a Class 1 canine key. The midline discrepancy has also been solved. For cases of excessive overjet, but good edge-to-edge bite profile, we can strategically level the maxillary and mandibular dentition using twin block appliances. Afterwards, we can engage mio on the mandible and maxilla and use elastics in the direction of the correct occlusal relationship. The treatment process in mio orthodontics is as simple as this. For cases of Class 2 malocclusion, we must initially evaluate the edge-to-edge bite profile. Thank you for watching.